I'm going to talk about Inspire CF, and funny enough, Inspire CF started a similar sort of time as the Activate study, and hopefully will inspire you as these children inspired us for this trial. Let's just see if we can get that. Good. So Inspire CF was a longitudinal study, and we looked at the effects of supervised exercise on lung function, exercise capacity, quality of life, and health economics in children with cystic fibrosis. And I undertook this as a part of my doctoral training at the Institute of Child Health and Great Ormond Street Hospital in the UK. Our pilot study was the frequent flyer program, and it was on this that we based the study. And in fact, on the study that was done in Australia sometime just before that, we really sort of based our trial on this, and it was looking at, our pilot study looked at sort of the sickest group of 16 children within the hospital, and we provided them with a personalized, individualized training program, and we had significant changes in aerobic tolerance and capacity within the group, some stability in their lung function, and then some cost savings. And so we were able to put a process forward, really, where we looked at feedback from the children that said, I just want to feel normal. And even in the group of the 16 sickest children, this idea of being normal seemed to dissipate through all of them. And in fact, at the end, many of them said that they were participating more in exercise and actually felt that they were participating along at the same level and sometimes even better than their peers. And this really ticked a box for the hospital because they have a big focus, obviously, on children's outcomes. And obviously, from a CF point of view, this seemed to be a big tick box for potentially some cost saving, but as well as improved outcomes in children. And so Eleanor Main and myself received funding through Great Ormond Street Children's Hospital, and we carried out a single-centered, non-blinded randomized control group with parallel groups and with intention to treat analysis. We had ethical approval, and we were registered as a clinical trial. So we aim to evaluate the longitudinal effects of exercise on lung function, exercise capacity, quality of life, and health economics in children aged 6 to 15 in a single-centered randomized control trial. And we were looking for differences, if any, between the two groups in lung function, exercise capacity, quality of life, and then health economics. Now, we set out, of course, to include any children who were diagnosed with cystic fibrosis, and we wanted as wide encapsulation of lung disease severity, and we wanted to include children as young as 6, and we were looking to include the upper end of children before they transferred into adult care. So the youngest sort of age we would be able to keep them in the study for 2 years would be to enroll them at around 15 and a half years, and they'd exit out at around 17 and a half, but we'd have them for the full 24 months. All of the children were under the primary care of Great Ormond Street Children's Hospital, and some of them were treated, well, they were all treated primarily within the hospitals, but some of them were under the care of shared care hospitals. And this, of course, proves some of the challenges, because when you're trying to do a health economic analysis, we couldn't extract that type of data, but we managed the children as best as we could do under our umbrella. And in fact, the majority of children were admitted to the hospital, and I'll talk to you a little bit about that shortly. We needed children to be able to perform spirometry, and they needed at least a baseline FEV1 of 40% or higher. Both children, parents signed consent, and we had a very clear directive at the beginning that we wanted all children to sign assent. So we wanted them to be brought into the study. And we spent a significant amount of time talking to children and their families about the control group and the exercise group, because of course we know that most people want to be involved in exercise, but we talked about the control group, and we really tried to get children to understand what it meant that they would still be contributing to perhaps a wider understanding of CF over time. Children were excluded if they'd undergone lung transplantation, but if they were listed for transplant, and currently if they were listed for a transplantation, and if they didn't sign consent, or if there were any impairments that the GOSH CF team felt would limit participation. And in that sort of sense, it was things like autism or underlying sort of difficulties in sort of communication. So just to tell you a little bit about the setup. So within Great Ormond Street, there were 104 children, of which there were around 84 children who were between the age of 6 to 15, and we invited them all to participate. Those that provided written consent were then pushed forward to do baseline testing. 13 children didn't give us consent. Some of those children were already taking part in exercise. They were living too far away from the primary sort of centers where they may have been centered, or simply didn't want to be participated in exercise. At baseline, we did a multiple breath washout test. We did spirometry. We did a cardiopulmonary exercise test, which was a cycle-based test based on the Godfrey protocol. We did a 10-meter shuttle walk test based on the level 27 test that had been just recently validated by Mark Elkins. And we did the UK version of the CFQR. We had 71 children who were then randomized after baseline assessment. 34 children were involved into the control group. 37 enrolled into the intervention group. Our control group received the current model of CF care as they knew it at Great Ormond Street, and our intervention group also received exactly the same care, plus a weekly supervised exercise program, and this was provided at local gyms in a relationships that we already had set up and then we developed, and I'm happy to discuss those sort of a little bit later on in a sort of question base, how we did that. But each of those children received a personal trainer, and there were 4 of us. There was myself and 3 others. We branded ourselves as personal trainers, and we went out to children and we trained them in local gyms or local at schools where there was a fitness facility. We reassessed the children at 6 months, and then again at 12 months, and again at 24 months, and we repeated the baseline tests. We then done some data analysis, and we're in the process of disseminating those results. What I should tell you is that the repeat of, or the data that I'm going to talk about today is going to be based on baseline and 24-month changes. Our primary outcome measure was FEV1 in 1 second, and this was calculated as a Z-score or standard deviation score using the Global Lung Initiative multi-ethnic reference equations. Our PAL calculation showed us that we needed at least 33 participants per group to provide a 80% power at 5% significance. And we were looking to detect a mean within subject improvements of 0.7 of a Z-score, so roughly about 10% in FEV1 over 2 years. And the study was powered on differences anticipated at 2 years. Our secondary outcomes included lung clearance index, 10-meter modified shuttle walk tests, and we looked at distance walked run, which I'm going to talk about today. And we also looked at changes in levels. We did a cardiopulmonary exercise test, and I'm going to talk today a little bit about work rate predicted, VO2 peak, and VO2 peak predicted. And then from a quality of life, the domains that were pertinent to our study from the CFQR were physical, treatment burden, and respiratory. And then in terms of health economics, we looked at admission types, the exacerbations versus routines and length of stay, and then the cost of overall healthcare. So at baseline, we had, there were 34 children recruited into the control and 37 into the intervention. And in terms of a mix between male and female, there was pretty even between both groups. We split an age groups into 6 to 8, 9 to 11, and 12 to 15. And we more or less had even matches between them. And in terms of disease severity, the vast majority of children had an FEV1 that was above 70%, and 7 of those children were below 7%, slightly more in the control group. The areas that we recruited from were the areas that children lived, and this is the Great Ormond Street capture area, which was London, the Hertfordshire, Bedfordshire area, and Essex. And we had an even split between all of those areas. And this was important for us to give as much opportunity for children to participate, but also it would allow the personal trainers to be able to access those areas and to focus on children in specific areas. And we also accounted for Nuffield memberships, and the Nuffields are a gym group that Great Ormond Street has partnered with, and they offer a free membership to children. At the time of the study, it was a relatively new initiative. Some children had taken up a membership, and that membership was active. Whether they were participating in exercise at those gyms wasn't all clear, because most children said, yes, they'd signed up and maybe been for one session, but it hadn't really sort of come. We felt we should account for that. And so gender, age groups, disease severity, area, and Nuffield memberships were our minimization criteria that we used in which to randomize the two groups. In terms of gene mutation, the Delta F508 homozygous group were by far the primary focus of the group that were recruited, and as most people would be familiar, that's probably likely similar in your own clinics. We had 3 children who had the Delta F508 to a G551D. They weren't on either catheter at the time, and I'll talk to you a little bit about those ones who came into this, who were in the study and were prescribed that. In terms of pancreatic insufficiency, almost all the children were pancreatic insufficient, bar 1. So just as a little bit what we did, hopefully this will play all through for you. So we got the kids into the gym, we did some exercise testing, we got them to do some strength testing, some strength training, we got them to do some cardiovascular training. We had a full Encompass program, and we had a 3-stage program. I'm not going to cover it all today, but I hope they'll tell you more about that when we publish it. And then we got the kids back in to do some testing, and we tracked these kids over 2 years. We had a huge amount of fun. You can see most of them are smiling. Let's see if we can go on here. So just in terms of attendance, we had between baseline and 12 months, we had a 58% attendance, but we had ranges between 9 and 92% attendance. Between 12 and 24 months, this had increased to 64%, but individual ranges between 11 and 91%. And over the entire period, our total period, number of or percentage of attendance was around 63%, which we actually thought was pretty good. But I'm going to draw your attention to this sort of side here where there's this 16 to 90%. There's quite a wide range there. Now, the vast majority of our children were attending, but we had a few stragglers along the way, and they were certainly challenging for us. So there was about a total of 104 weeks of training. So on average, children attended about 66 of those 104 weeks, but we had one boy who attended 99 out of the 104, and one teenage girl who attended 17 out of the 104. Overall, males attended more sessions than males, and there was a 58% to 68% attendance between the two. And this was for the 34 of the 7 children who completed the full program. So that we had 4 dropouts out of the total of 71, and we had 1 from our control group and 3 from our intervention group. So the reason for non-attendance to group was largely centered around whether there was a fitness center that was prepared to host them. And in the initial first 12 months, we did struggle a little bit. It was partly to do with some insurance problems between the gyms, but once that was uptake, we pretty much had everybody in. So that affected about 6.4% of the reasons for non-attendance. And then family holidays and trainer holidays were at the sort of next level reason. In fact, attendance to hospitals and clinics only accounted for 2.8% of the missed time. As probably you would expect from a CF population, we had a huge amount of variability in both groups, both in the control and the intervention group. When we looked at the outcomes, so our primary intervention was FEV1, and at baseline, the groups were pretty similar. And although there was a non-significant difference of FEV1 Z-score being slightly higher in the intervention group. Over the 24-month period, well, at the end of the 24-month period, there was still this difference. It was still a non-significant difference. We have adjusted these this data using a regression analysis and a multi-level model. And I'm going to talk to you a little bit about the necessity to really try and tease out what's going on with lung function, because in reality, we probably all know it's a pretty blunt tool, but it's kind of, if you want funding in CF, you kind of need to have the FEV1 that's in there. But change overall for our group was roughly around sort of 5.4% difference between the two. But for the vast majority of our patients, they had pretty good lung function. When we look at the trajectory of the FEV1 Z-score over the 24 months, you can pretty much see that there was a deterioration in both groups, less so in the intervention group than the control, but they were the better group at baseline. Average deterioration within each group was about 1.5 FEV1% over each year of the study. We looked at where we included the multiple inert gas washout test. And this proved to be quite an interesting test for us because it looks at the smaller airways. And there was an approaching significant difference at baseline, with the exercise group having slightly better lung function. And this difference was there still at the end of the 24 months, again approaching significance. It looked like the exercise group may have had a slight reduction in the deterioration of their lung function, probably more so based around their lung clearance index than the FEV1. When we set out with the program, we had asked children from the frequent flyer program to tell us which of the exercise tests that we've done between the modified shuttle walk test and CPET, which one would they prefer to do? And they felt that the modified shuttle walk was much more relevant to them. They understood it. Lots of them did bleep tests at school for PE, and they understood the concept behind it. And so when we set out at baseline, our exercise group ran slightly less distance than our baseline group, than our control group, but after 24 months, they were running significantly further. The adjusted difference for this in the from our regression analysis actually increases this difference to 225 meters, which we think is pretty important. In terms of levels, we had a significant change of at least one level. Now, based on the fact that this was the 20-level test, the highest level that was completed by one of our patients was the 18th level. You also know that recovery, we used the Omni as our exertional scale, and there was a significant difference at the end in terms of children saying that they felt that they'd worked harder, and that was probably relevant because they'd run further. But in fact, their recovery time was also significantly better post modified shuttle walk test. When we looked at the cardiopulmonary exercise test, when we looked at work rate predicted, both groups at baseline, well, if we look at just in terms of the differences between the two, there was about a 9.4% difference between the two. This was a non-significant difference at baseline. However, after the 24 months, the difference had slightly narrowed to 5.4. But in terms of the ability for children to reach their predicted, they're pretty much setting in those upper ranges. So we probably started off with a relatively fitter group, which may be representative of the CF team being quite focused on exercise and encouraging exercise. And we certainly weren't stopping children exercising by taking part. In terms of VO2 predicted at baseline, both groups were around the 85-84% exercise groups slightly lower at 1% lower. After 24 months of intervention, both groups had increased their VO2 peak, and in fact, some of them were attaining a full 100% VO2 peak. So we didn't manage to show any differences between the two of this. We've delved a little bit deeper. Ella and I are still trying to tease out what's been going on. Why did we show the difference between, or these sort of huge differences in our 10-meter shuttle walk test versus not the cardiopulmonary exercise test? Of course, this was a fitter group. That potential to change your VO2 peak is so much harder, but nevertheless, an interesting outcome for us. In terms of the cystic fibrosis questionnaire, we were interested in 3 of the areas: physical functioning, respiratory symptoms, and treatment burden. There were no significant differences between the groups at baseline in terms of physical functioning, but the exercise group reported a lower quality of life in physical conditioning. However, this had increased towards the end of the program, and that was quite reassuring to us because obviously they were doing physical exercise. Respiratory symptoms, the exercise group felt that they weren't managing quite as well as the control group at baseline, but they felt they were managing slightly better at the end of the program. Treatment burden was a focus for us because when we're going to take a supervised exercise program and effectively provide more care, seeing patients week on week, this really was likely to increase treatment burden, and we were concerned about this. And this was probably reflective already in our exercise group at baseline, where there was this 10-point difference and a significant difference in terms of treatment burden. But interestingly enough, at the end of the 24 months, the control group's treatment burden had deteriorated, whilst the exercise group's tolerance for additional treatment had actually improved. In terms of the health economic sort of components, for the vast majority of admissions were centered around routine admissions and admissions for exacerbation. And over the 2 years, there were 241 individual admissions to hospital for a range of outcomes from endocrinology, gastroenterology, bronchoscopy, surgery procedures, sleep studies, and those were all very, very small percentages compared to the primary routine and exacerbation. In terms of all admissions, so we had some interesting data that came out. At baseline, the children in the exercise group had spent approximately 1 day longer per admission, whereas at the end of the study, they had spent close on 3 days less per admission. And this was sort of replicated when we look at exacerbations and routine, which were the primary measures. Exercise group was spending about 2.2 more days longer in hospital. By the end of the study, to 2.3 days less in hospital. So what does this all come down to in terms of IV antibiotic requirements? Both groups were pretty similar at baseline. Intervention group spending slightly longer in hospital. At the end, the intervention group spending slightly less time in hospital in general. However, when we break down the exacerbation and routine, what was interesting at baseline is that the intervention group was spending a lot longer in hospital, but this was not significant, so 5.7 days longer. Whilst at the end of the study, both groups had reduced their time being spent in hospital, but more so in the exacerbation group by almost 4 days left. When it came to routine, at baseline, the exercise group was spending less time in hospital, and compared to the control group, both groups went up in terms of the length of time they were spending in for routine admissions, and in fact, more so in the exercise group. Now, when we've looked at this data just a little bit clearly, it is possible that some of the children who may have been coming in for a routine admission may have been picked up by the exercise intervention, or sorry, the exercise research team may have picked up that there was an earlier exacerbation of symptoms, and those children were admitted earlier, still under a routine admission. So it is possible that some of this data is a bit obscured because of those admissions. We did try and rectify this with the CF team, but it is possible that this didn't filter all the way through to the patient information systems where all of our data was extracted from. In terms of healthcare costs, as you guys can expect, there was a significant cost for the 2 years. So this was this covered everything from staffing, the setting, clinical type supplies and overheads, any type of intervention, and then the low and high cost drugs. What's not included here is the ivacaftor, and I'll talk to you separate about that if you want to ask a question around that at the end. So overall, the group costs about $4,652,000. At baseline, the exercise group was costing slightly more, and in each of the subsequent years, costs went up for all of the group, and this was partly to do with an accounting change within the hospital and the inclusion of overheads, which hadn't been included before, and this is partly to do with the structuring and the funding of CF in the UK, and this went up again in the second year, but in all of the years of the subsequent years of the intervention group cost less. And in fact, when we look at the mean differences, these are the adjusted differences. The mean difference at baseline was about $517, pounds. This went to 3,674 and all the way up to 5,645 towards the end. So each year there was an adjusted saving for the hospital for those children who were in the intervention group. So you'll remember at the beginning that I said we had this little problem where we had 63% attendance, but we had this really wide range between 17 and 99 out of the 104 weeks. Now, I should tell you that children made a real effort to come along, and the ones that we're talking about here, this lower group, really are with the struggle teenagers, really sort of putting up a fight. Perhaps exercise was never their favorite subjects, and they thought we might work a miracle on them. And we were interested to see if there was a dose effect of exercise. And so what we did is we did a multi-level mixed model, and we looked for the association between FEV1 as our primary endpoint and the number of days of exercise that the children did. And what the model suggested was that if we take this sort of arbitrary number around sort of 52 weeks, you can see that this is where there were a number of children who started to, or who showed an improvement in their FEV1. And it showed that there was this association such that children who did at least 52 days of exercise could expect the small change in their FEV1 around 0.16 of a standard deviation for every day that for every week that they were exercising. And when we extrapolated this out, we found that FEV1 could improve by, or they could expect improvements of up to 0.83 of a standard deviation, which equates to around just over 10% in FEV1. And this is very similar to the type of findings that are coming out from the new drugs that children are being prescribed. So what can we conclude? There were no overall group differences between FEV1 in FEV1 Z-score. However, there appears to be this dose-related effect of exercise on FEV1 in the intervention group, and there may be an indicator that exercise does preserve lung function to some extent, and this requires further examination. Understanding more about this in the future will help provide recommendations for the minimum level of exercise required to have an effect on lung function and other health outcomes. There was a significance in 10-meter shuttle walk test distance. Children with CF could match or exceed their peer groups on the sports field, and this was important to the children. We showed no significant change in work rates or in VO2 peak, which may reflect the large number of children which were already physically active and able to exercise at moderate high intensity levels. And both groups improved outcomes, which is clinically important for both groups. The intervention group spent less time in hospital and cost less year on year than the control group. So in the preceding year to the study, the exercise group had actually cost 5.1% more than the control group. However, at 12 months assessment, this difference had been reversed, with the exercise group now costing 7.1 less than the control group, and this were further extended at 24 months to a 19.3 less cost than the control group. So the overall cost showed that the exercise group cost 13.7% left. So we had an approximate cost saving of around £250,000 throughout the duration of the study, which is obviously significant for a hospital. So what did kids say? I participate more in PE lessons, go to after-school clubs, and I've captained the cross-country running team. I feel more normal, and I think exercise is fun. Having a personal trainer was awesome. I still hate the treadmill. Children hated the treadmill, but I thought I'd just demonstrate at least what we managed to get the kids to do. So this is Daniel, and colonized with Pseudomonas and with MRSA. Did very little exercise at the beginning, but completely took to doing exercise. And so we got the kids to do high intensity interval training, and some of those intervals, this is him running at 19 kilometers an hour. He would do 19 kilometers an hour followed by walks of 5 kilometers an hour, and then he'd go back up to those ranges. Good, so nice and happy. I did some resource development. So I filmed all the exercises that we got to do. I'm still developing this resource and hope they'll get it out sometime this year. But I basically broke down each of the exercises, how they should be done, and basically what the exercise was for, which I thought was pretty useful. And it used basically explained the equipment that we were using. So lessons learned. Not really too sure whether FEV1 should be considered a primary outcome for an exercise intervention. I think most of you would agree that it's probably done its time within its CF, but I don't think it has a place in exercise much anymore. LCI might offer some insight into small airway changes and requires more research. The 10-meter modified shuttle walk test was much more relatable to the children. If anything, we got a lot of complaining with CPET, and they were great, but we need to learn how to tease out those changes that are occurring from exercise programs, as this is going to be important for clinicians. We need some we need some education on the benefits of CPET for patients. And a dedicated lab would be ideal. We were testing in a very busy cardiac testing lab, and this put a huge amount of pressure on the team and on the cardiac team. So any sharing of business cases that you guys have used for development of programs would be really useful. We detected a case of Wolff-Parkinson-White syndrome, which suggested that perhaps ECG monitoring at annual review would be something that could be of relevance, and reporting these changes in arrhythmias would also really be important for all of us. Just lastly, supervised exercise is hugely time consuming, but we built fantastic relationships with gyms, and those development with health facilities and personal trainers is a really worthwhile process, particularly for the longevity of the groups, longevity of the program. Exercise should be implemented early in childhood to augment the routine through adolescence and into childhood. Health economic data is key to convincing decision makers on implementing these programs, but boy, it's hell of a difficult to try and get all the data collated. This study may represent the new CF. Maybe we need to rethink our approach to exercise, and I think I probably heard that quite a lot today from you guys, that perhaps we're at that point of rethinking things. And are we underestimating children's participation in exercise? Should we start believing what they're telling us? Thanks very much, everybody. Thanks for having me. And be delighted to take any questions if there are.